And for our, well, first of all, let me welcome the first panel and the two gentlemen, and let me introduce you. On my left is Glenn Hackbarth, who's the chairman of the Medicare Payment Advisory Commission, or MedPAC. And to my right is, or to his right, is Douglas Elmendorf, who's director of the Congressional Budget Office. And we're really looking forward to your testimony. I've kind of looked at some of the written testimony, and you deal with very effectively with new ways of doing things and the whole cost efficiencies, which are so important to us. We'll start with Mr. Hackbarth.
Thank you, Mr. Chairman and Ranking Member Deal. I appreciate the opportunity. Many of my comments in my opening statement will echo themes that have already been heard. Let me begin with a brief definition of health reform, at least in my mind. Health reform equals expanded coverage plus lower cost growth while maintaining or even improving quality of care. MedPAC's focus, as you well know, is on the latter set of issues, in particular using payment policy to improve the efficiency and the effectiveness of the care provided to Medicare beneficiaries. And in some quarters, this has been labeled moving the system toward high performance. Let me start by emphasizing that the U.S. healthcare system has tremendous resources in the professionals who serve in that system. I've been fortunate in my career to work with talented physicians and advanced practice nurses and psychologists and other professionals, and I know what talent and commitment they bring to their work. The problem we have is that Medicare's payment systems and those of most private insurers reward more care, more complex care, without regard to the value of that care to the patients. But equally important is that Medicare's payment systems enable what we've referred to as siloed practice, whereby individual clinicians and organizations act independently of one another, even while caring for the same patient. Too often, efforts at coordination and integration of care are sporadic, and where they occur, they're testimony to the commitment of individual professionals. They're not inherent in the system itself. The result is that care is all too frequently fragmented, duplicative, and gap-filled, and on occasion even conflicting, as is the case sometimes with adverse drug interactions. Care of this sort isn't just expensive, it's dangerous. And it's dangerous in particular for patients with multiple complex illnesses, which is a common problem, as you well know, in the Medicare population. In the last several years, MedPAC has recommended a series of changes in Medicare payment policy that we believe would help move health care to a higher level of performance. And let me just quickly mention some of those recommendations. First is increased payment for primary care services, and perhaps a different method of paying for primary care services as is embodied in the idea of a medical home. Research demonstrates conclusively, in my view, that a strong primary care system is the foundation of a high-performance health system. In the United States, at this point, our primary care system is weak and rapidly deteriorating. Second recommendation has been that we begin providing confidential, episode-based feedback to physicians about their practice so that they can better understand how their practice compares to their peers, both in their local area and in their specialty. Third, we've recommended authorization of what we refer to as gain sharing between physicians and hospitals. The goal here is to encourage collaboration between physicians and hospitals, both in reducing cost and in improving quality of care. Next, we've recommended reduced payments for hospitals experiencing unusually high levels of potentially avoidable readmissions. About 18% of all Medicare admissions are followed by a readmission within 30 days at a cost of about $15 billion per year. A sixth recommendation is a pilot of what we've referred to as bundling whereby payment for hospital and physician services provided during an admission would be combined into a single payment and perhaps combined with payment for post-acute services as well. Next, we've proposed reforms in the Medicare Advantage program so that participating private plans are engaged in promoting high performance in health care instead of offering plans that mimic traditional Medicare except at a higher cost. And last, we've urged public investment in comparative effectiveness research, which the Congress has already acted on in the Economic Recovery Act. This week at our MedPAC meeting, we will also be considering the potential for what we've referred to as accountable care organizations, organizations that assume clinical and financial responsibility for a defined population of patients. We'll be trying to figure out methods to pay such organization that could reward efficiency and reduce cost for the Medicare program. Let me close with two quick cautions about the challenge ahead of us. First of all, changing payment systems, and especially trying to do so quickly, requires a lot of resources. And I am very concerned, the Commission is very concerned about the level of resources that CMS has to pursue this agenda. A second caution is that while striving for payment reform, as important as it is, as vital as it is, we must also apply steady, indeed perhaps increasing pressure on unit prices under Medicare's existing payment systems. Thank you very much, Mr. Chairman, and I look forward to the discussion.
Thank you, Chairman Hackbarth. Director Elmendorf.
Thank you, Chairman Pallone, Ranking Member Deal, members of the subcommittee. I appreciate the invitation to talk with you today about the challenges and opportunities that Congress faces in trying to make the healthcare system more efficient so that it can continue to improve Americans' health but at lower cost. Policymakers could seek to improve efficiency by changing the ways that public programs pay for healthcare services or by encouraging such changes in private healthcare plans. In both sectors, these changes could in turn exert a strong influence on the delivery of care. To assist the Congress in its deliberations on this topic, CBO released last December a report titled Budget Options for Healthcare. Drawing in this report, my testimony makes three key points. First, a substantial share of spending on healthcare contributes little, if anything, to the overall health of the nation. Second, reducing unnecessary spending without also affecting services that do improve health is challenging. But many analysts would concur with the importance of providing stronger incentives to control costs and generating and disseminating more information about the effectiveness of care. Third, despite broad support among analysts for moving in these directions, there is substantial uncertainty about the effects of many specific policies, and many policies might not yield substantial budget savings or reductions in national health spending within a 10-year window. Let me discuss these points briefly in turn. First, as you know, spending on healthcare has grown much faster than the overall economy for decades. This imposes an increasing burden on the federal government, for which the principal driver of the unsustainable budget outlook is growth in per capita health costs, not aging. It also imposes an increasing burden on the private sector, where the growth of health spending has contributed to slower growth in wages, because workers must give up other forms of compensation to offset the rising costs of health insurance. When confronted with these costs, ever more firms and families drop their health insurance coverage. Concerns about the level and growth of healthcare spending might be less prominent if that spending was producing commensurately good and improving health. Unfortunately, substantial evidence, detailed in my written testimony, suggests that more spending does not always mean better care. The second main point is that many analysts would concur with the importance of providing stronger incentives to control costs and of generating and disseminating more information about the effectiveness of care. Many analysts would agree that payment systems should move away from a fee-for-service design and should instead provide stronger incentives to reward value. These incentives can be created in a variety of ways, including fixed payments per patient, bonuses based on performance, or penalties for substandard care. However, the precise effects of these policies are highly uncertain. Many analysts would also agree that the current tax exclusion for employment-based health insurance, which exempts most payments for such insurance from both income and payroll taxes, dampens incentives for cost control because it is open-ended. Those incentives could be changed by restructuring the tax exclusion in ways that would encourage workers to join plans with higher cost-sharing requirements and tighter management of benefits. Moreover, many analysts would agree that more information is needed about which patients work best for which patient, which treatments work best for which patients, and about what quality of care different doctors, hospitals, and other providers deliver. But absent stronger incentives to improve value and efficiency, the effect of information alone will generally be limited. Third, many steps that analysts would recommend might not yield substantial budget savings or reductions in national health spending within a 10-year window. There are a number of reasons for this. Again, further details in my written testimony, but briefly, in some cases, savings materialize slowly because an initiative is phased in. In other cases, initiatives that generate savings, such as prevention efforts or disease management, have costs to implement. In some cases, the federal budget does not capture the reductions in national health spending. In other cases, new structures for healthcare delivery improve health, but do not provide incentives for reduced costs. And in yet other cases, limited evidence about the effects on efficiency is available. Let me conclude with two general observations. One is that given the central role of medical technology in the growth of health spending, slowing spending over the long term will probably require decreasing the pace of adopting new treatments and procedures or limiting the breadth of their application. Such changes need not involve explicit rationing, but could occur as a result of market mechanisms or policy changes that affect the incentives to develop and adopt more costly treatments. The other observation concerns the urgency of healthcare reform. In contrast with the situation in the economy and financial markets, our system for delivering and paying for healthcare is not fundamentally different this year from last year. However, very few analysts think that the relatively gradual pace of change in healthcare is an argument for deferring reform. On the contrary, our current health system evolved over years and decades, and the thoroughgoing changes needed to substantially improve efficiency will take years and decades to come fully to fruition. Nearly all analysts think those changes should begin soon. Thank you.